Great. And today's webinar is being presented by Dr. Jason Zucker. Dr. Zucker is the Assistant Medical Director of the New York City STD HIV Prevention Training Center and is an instructor in the departments of medicine and pediatrics within the Division of Infectious Diseases at Columbia University Medical Center. So Dr. Zucker, I'll turn it over to you.
Good afternoon, everybody, and thank you so much for joining to talk about what you need to know about the prevention, diagnosis, and treatment of Mpox with updates on what's been going on. So the learning objectives for today are to recognize the presentation of Mpox, review how to diagnose Mpox, develop familiarity with treatment options for Mpox, compare the different vaccination options and prevention strategies for Mpox, and examine what we've learned since the start of this outbreak in 2022. So we'll start with Mpox epidemiology. So let's take a minute and go back to the beginning. As we learned with COVID, infectious diseases outbreaks can happen quickly, and that's what happened here. In early May, the first case was confirmed outside of endemic areas in England, which was quickly followed by other cases around the world, including the first US case about 1 month later. And what was just a few cases early on turned into a worldwide outbreak, with over 88,000 cases as of July 5th. And this rapid increase in cases led the World Health Organization to declare a public health emergency of international concern 10 weeks after the first case was reported. And once again, the US is at the center of the Mpox outbreak. The US has over 30,500 cases and remains #1 in the world. This led to on August 4th of 2022, the US declaring Mpox a public health emergency, freeing up needed resources. However, while we're #1 in the world, this epidemic has not been affecting everyone equally. 94% of cases have been in individuals who identify as males, the majority identifying as gay, bisexual, and men who have sex with men. Only 3% of cases have been in women, and only 2.4% of cases are in individuals under the age of 20. Now, the good news is that cases have declined dramatically from our peak of last summer. We'll talk about many of the reasons for that during the course of today. But what's very clear is that cases are way down from their peak in July and August of 2022. However, this is the 2023 cases map. And as you can see, we've had a 7-day case average of less than 1. But what we do have now appears to be ongoing and consistent low levels of transmission. And so these low levels of transmission is why it's important that all providers remain aware of Mpox and are prepared to include it on their differential and test for it if needed. This became particularly important recently when we did see a cluster of infections in Chicago, now greater than 50 cases, and we've also started to see clusters in other jurisdictions. So what is Mpox? So Mpox is a pox virus. It's an orthopox virus. This means that it's similar to smallpox, but not. This is important because many of the treatments and vaccines that were developed for smallpox have the potential to work against Mpox as well. There are actually many other orthopox viruses, including variola or smallpox, vaccinia, which the smallpox vaccine is based on, cowpox, rabbitpox, camelpox, and many other animal orthopox viruses. There are 2 virus clades, clade 1, which was formerly referred to as the Central African clade, which has a mortality as high as 10%, and clade 2. Clade 2A, which is formerly referred to as the West African clade, has a much lower mortality rate of around 1%. This outbreak has been specifically of clade 2B virus, which has shown over the course of the past year to have about a 0.2% case fatality rate. And the majority of those infections, as we'll see, are in immunocompromised individuals. In terms of transmission, it's important to highlight this is not easily transmissible. It can be transmitted from animals to humans, like prairie dogs, as has been seen during prior US outbreaks. And animal to human transmission can be from direct contact with infected lesions or body fluids, contaminated fomites, bites or scratches, or ingestion of animal products. However, while animal to human transmission is possible, this outbreak has been primarily human to human transmission. Human to human transmission primarily occurs through 3 ways: direct contact with infected lesions or body fluids, contaminated fomites, or exposure to respiratory secretions. And because of these 3 ways, the CDC continues to recommend the following infection prevention and control methods for anyone seeing a patient with suspected Mpox. This includes a gown, gloves, eye protection, and an N95 respirator. However, in spite of this, even when not used appropriately, transmission to healthcare workers is rare. There was a review that, healthcare worker exposures in Colorado, there were 313 people in the ED who were exposed. Overall, because it was the emergency department and because they didn't necessarily know people were coming in with possible Mpox, the use of recommended PPE was low. Only 23% used all PPE. 12% received PEP with the modified vaccinia and anakinra vaccine, and all were monitored for 21 days. None of them acquired Mpox. There was also a systematic review that identified only 10 worldwide cases of nosocomial transmission, with Sharp's injury being the most common route of acquisition among cases reported. So again, this is not an easy disease to transmit. So whenever I talk about transmission, I get all sorts of questions about, can I get Mpox on the bus or subway, grocery store, clothing store, gym, salon, or classroom, or any other place that I go frequently? And the answer is probably not. While I did list out 3 ways for human-to-human transmission to occur, the epidemiology of this disease has really highlighted one. And that's direct contact with infected lesions or body fluids through close, personal, skin-to-skin contact with Mpox rashes or scabs. This close physical contact, like occurs during sex, is by far the most common way to acquire Mpox. While contaminated fomites, particularly soft porous items like sheets, and respiratory secretions have all been reported as potential ways of transmission, that has not been what we're seeing in this outbreak. What we're seeing in this outbreak has been a lot of sexual transmission. There's been a lot of discussion about whether or not Mpox is a sexually transmitted infection, but whether or not it is, it's pretty clear that the close physical contact that occurs during sexual activity is a driver of transmission. Additionally, there's a pretty clear relationship between sexual activities and transmission. This includes an anatomic association between sexual practices and lesion location, with people with proctitis being 5 times higher among those engaging in receptive intercourse than those not. We also see that close physical contact is the likely driver when we look at transmission again. While anyone can get Mpox, in general, that's not what we're seeing. If this was airborne transmission, we'd expect to see a lot more infections in women and children. Instead, what we saw was an extremely slow expansion of the epidemiology, more consistent with close physical contact than respiratory or even fomite transmission in public. One thing that is important to know is that it is possible to transmit before symptoms start. In the study on the left, they found that viral DNA was detected as early as 4 days before symptom onset in 5 of 18 patients, with 3 of them having replication-competent virus, suggesting the possibility of transmission prior to symptom onset. Additionally, on the study on the right, they did contact tracing and identified pre-symptomatic transmission that likely occurred in 5 of 18 pairs. And so while transmission is primarily via close physical contact, it likely can occur in a pre-symptomatic phase, which makes sense and may help explain how the outbreak spread so quickly. So now that we've covered how it spreads, let's take a second to talk about how it presents. This is the classic presentation, or what you would have expected to see if you read a book on Mpox prior to 2022. The disease classically starts with a viral prodrome similar to many illnesses. This includes fevers, chills, headaches, malaise, myalgias, and lymphadenopathy. After the prodrome, patients usually develop a rash. The rash is firm, deep-seated, well-circumscribed, and sometimes umbilicated lesions. And we'll see a lot of pictures of the rash coming up. The rash usually occurs before day 5 and most commonly on days 1 to 3. The rash classically starts in the face and spreads to the extremities, including the palms and soles. And the rash classically progresses through several synchronized stages. It can be extremely painful, lasting for up to 4 weeks. So this is the classic Mpox timeline, starting with the incubation period of 5 to 21 days, which means it's important to highlight the fact that after an exposure, it can be up to 21 days before you'll have any symptoms, although it more commonly occurs around day 6 to 7. That's followed by the prodrome we described earlier, followed by an anathema, which are lesions that start in the mouth. During this period, you can have infectious virus in your mouth that can spread through kissing or oral contact before you may even realize you're infected. That's followed by macules, which are flat lesions on the skin, And because they're small and flat, they're very easy to miss. These are followed by papules, which are solid and superficial and not yet fluid filled. They're less than 1 centimeter in size and look a little bit like acne. These can then progress to vesicles, which are less than 1 centimeter as well, but contain clear fluid. Further progressing to pustules, which are filled with a darker fluid consistent with pus. They can also become umbilicated at this stage, developing a hole in the center, which is really classic for this disease. After that, they start to scab. And it's important to know that the scabs are still infectious. Patients are not considered fully resolved and no longer infectious until the scabs have fallen off and there's new fresh skin underneath. Because of that, the infectious period is long. The infectious period lasts from when the prodromal symptoms start until the scabs fall off. Patients can be infectious for as long as 28 days or longer, which makes managing this disease very complicated. And it's very hard on our patients' lives to be isolated or quarantined for up to 28 days. So to understand how Mpox is presenting differently during this outbreak, we looked to a few case series that have been published. And we did our best to put some of these findings into a table to help us identify some of the trends. One of the first things that's very obvious is that the majority of cases in this outbreak are male, greater than 95% in most case series, compared to only about 2/3 male in the African case series. This is likely related to how the disease is transmitted across sexual networks than anything about the virus itself. Another important thing to note that's not noted on this table is that a disproportionate percentage of patients, around 40% across studies, are persons with HIV. Second is that while we're going to hear about a lot of other symptoms, the rash is still common and prevalent in most patients. However, what you can't get from the table is that in some cases, the rash appears after other symptoms instead of being the initial symptom. One of these major symptoms has been rectal pain, presenting as proctitis with and without tenesmus, occurring between 14 and 36% in these case series, and it's one of the major unique symptoms of this outbreak. And this symptom also fits with lesion location. The majority of patients have lesions on their genitals or anal perianal regions, and these are frequently the locations the rash begins as well, differentiating it from the classic presentation. What's also interesting is that we're not seeing huge numbers of lesions like reported in African case series. In this case, the median number of lesions is around or less than 10. I also want to highlight some of the presentations with images because I think it's important to see. We want to thank our patients for providing us permission to share their stories and images, and some of the images on the next few slides will be graphic. So these are some of the presentations we'll look at today. Genital lesions have been consistently a feature of this outbreak, and you can see umbilicated lesions on the genitals here, umbilicated lesions in the rectal area here, and umbilicated lesions in the vaginal area here. Next, we have proctitis. And again, proctitis has been a very common portion of this outbreak. And you can see here a sigmoidoscopy showing rectal ulcerated lesions. Patients can have persistent symptoms from this. Urethritis, so presenting like a sexually transmitted infection like gonorrhea or chlamydia, patient presenting with pain on urination or dysuria. And you can see in this case, the patient had 2 lesions in his urethra that were irritated each time he urinated. Pharyngitis has been another common presenting symptom during this outbreak. And in fact, this has been one of the major reasons for admission to the hospital because patients have been unable to tolerate PO intake due to painful pharyngeal lesions. Ocular disease has been another one often presenting during this outbreak and has also been well described in the African case series. Most cases of ocular disease have been reported as being likely secondary to auto-inoculation, but ocular Mpox is a sight-threatening condition, and patients with ocular Mpox need to be considered for urgent ophthalmologic evaluation and treatment. Lymphadenopathy can be pretty severe. Patients often have lymphadenopathy around the site of their lesion, so patients with pharyngitis may have cervical lymphadenopathy, and there are reports of such large lymph nodes that it can compromise the airway. Patients with rectal disease can often have rectal lymphadenopathy and painful lymphoid tissue. And patients with genital disease often have inguinal or abdominal lymphadenopathy that can present with significant swelling. In this patient's case, he came in struggling to walk, reported to feel like he had a fanny pack inside of his stomach. Bacterial superinfection, particularly of areas that are hard to clean, like the genitals or rectum, have been a common presentation of this outbreak as well. Here you can see that 4 pictures of penile infections that we saw and managed during the course of this outbreak. One thing I do want to highlight is that with careful management, these actually can improve and get better. And you can see that these all healed, although with some residual scarring. It's important to know that Mpox can be a severe disease, particularly in those individuals who are immunocompromised. In this outbreak that has been mostly persons with HIV, as you can see from the chart on the right, the orange line is individuals with CD4 counts less than 100. And you can see that they have many more complications than those individuals with CD4 counts from 100 to 200, which is the purple or lavender line, much less than those who have CD4 counts 200 to 300, which is the blue line, and less than those with greater than 300, which is the green line. So patients with lower CD4 counts do have higher complications. And these complications may include persistent or progressive disease. Patients have been presenting with prolonged Mpox infections, unable to clear, and developing these large necrotizing lesions that can continue to progress despite our best efforts. Finally, encephalitis, there have been several reports of encephalitis related to Mpox, both in immunocompetent and immunocompromised patients, and they can be a devastating disease. So to briefly summarize Mpox presentation during this outbreak, it's occurring primarily among gay, bisexual, and other men who have sex with men, with a smaller number of infections spreading to women and children, likely via household spread. The typical rash is common, but it's often presenting atypically. Starting in the genital perianal areas, and mucous membrane involvement is common. You can have scattered or diffuse lesions or localized to a single body site, and lesions do not have to be synchronized. You can have different stages of progression seen side by side. Regarding the prodrome, it may or may not be present. It may occur after the rash or other symptoms start, and non-skin lesions may actually be the presenting symptoms. Because of all of this, a high index of suspicion is needed to make sure you don't miss cases of Mpox. How do you diagnose Mpox? So now that we know how to identify it, how do we prevent or diagnose it? And the differential diagnosis for Mpox is broad. Patients can present with a diffuse rash, which can look like the rash seen in syphilis, varicella, HSV, molluscum, other pox viruses, disseminated fungal infection, disseminated gonococcal infection, and particularly in children during the fall, enteroviral infection. And I can tell you that we have been fooled by many of these differentials over the course of the past year. For patients with genital ulcers, it's very hard to tell the difference between Mpox and HSV, syphilis, chancroid, and LGV. And patients presenting with proctitis, it's hard to tell the difference between gonorrhea, chlamydia, including LGV, HSV, and syphilis. You notice that syphilis is in red and presents with all 3 of these presentations, as we've had many patients that we thought would have Mpox that had syphilis, and many patients that we thought that had syphilis that had Mpox. Additionally, just because patients have one doesn't mean they can't have the other. And co-infection with other STIs is common. 38% of patients at the time of the CDC study had coexisting HIV diagnoses, and 41% had had an STI in the past year. In terms of diagnosis, Mpox DNA has been identified in seminal fluid, rectal swabs, urethral swabs, respiratory secretions, blood, in addition to skin swabs. However, with that said, when you look at the viral loads of different samples, and that's here, you can see that the CT values representing viral loads are here, and lower CT values represent a higher viral load. The highest viral loads are those seen in skin, then rectal swabs, then throat, blood, urine, and semen, really suggesting that skin may be the best site to make a diagnosis if patients have skin lesions. Additionally, not just the skin have the highest viral loads, but skin lesions are also around for the longest. If you look here, rectal lesions have a time to clearance of about 50% of patients about 14 days, while skin lesions have a median time of 25 days. Not just that, but about 95% of patients to clear, skin lesions can take up to 47 days. And so skin lesions have higher viral loads and longer persistence. So they really are the best place to look for Mpox when making the diagnosis. And maybe it is entirely skin lesions that are responsible for transmission. Currently approved for diagnosis is to do a PCR from a lesion swab. These can be either sent to your local lab, commercial labs, or public health labs. As we just showed, these lesions tend to have extremely high viral loads, so you don't need to unroof them, but just swab them vigorously and follow local procedures for the medium to use and sending it to the lab. As a reminder, we should not unroof the samples because this leads to an increased risk for the provider, as we talked about a little bit earlier. It's also good practice to swab at least 2 lesions, as we have had some where one of the 2 lesions tested negative. Serology also exists with IgM and IgG ELISA assays to orthopoxvirus. However, in general, the IgM turns positive about 5 days post-rash onset, while IgG turns positive at about 8 days post-rash onset. It's unclear during this outbreak if it's truly from rash onset or could be from other symptoms if they start first. And one of the major challenges is that the assay cross-reacts with vaccinia virus after receiving smallpox vaccination, which many patients have and are now receiving. Additionally, it's not commercially available, although it is available from the CDC for certain circumstances. One big question is current testing enough? And so that's an important question. And I mentioned earlier that pre-symptomatic disease can occur. But what about symptomatic disease? Well, in this study out of Belgium, they retrospectively screened 224 samples that were collected for gonorrhea and chlamydia testing. They found that 3 anorectal swabs and 1 pooled sample were positive for Mpox virus. And these findings demonstrate that asymptomatic cases of Mpox do exist and may contribute to ongoing spread. Because out of these 4 positive samples, 3 of the 4 never developed any symptoms. All 3 had positive serology, and 2 of the 3 had cultural bull virus, again suggesting the possibility of transmission. And so it's likely that asymptomatic cases do exist and may also contribute to ongoing spread, in addition to pre-symptomatic spread. Now, if your patient has Mpox, what can we offer them? How can we treat them? The first and most important thing is that most patients fully recover with or without treatment. As we mentioned earlier, the case fatality rate is about 0.2%, the majority of whom have significant immunocompromise. However, at the same time, you saw a lot of the pictures we showed, and in spite of mortality being low, there is considerable morbidity, and supportive care can help patients while they're recovering. Most of the symptomatic treatment recommendations are not strictly evidence-based, but they make sense, and the CDC has collated the experience from a variety of providers to put together a Dear Colleague letter. Supportive care recommendations include for proctitis, stool softeners to decrease pain when going to the bathroom, and especially for patients who end up on opioids. Topical agents like sitz baths and lidocaine gels, but be careful with local immunosuppressives with the potential to worsen disease. This also includes over-the-counter pain relievers like NSAIDs if not bleeding, or Tylenol. And finally, prescription analgesics like gabapentin or opioids. I always recommend care and consideration with opioids due to the risk for constipation making things worse, but there are patients whose pain we have not been able to control any other way. For oropharyngeal lesions, we have topical agents like viscous lidocaine and saltwater goggles, as well as the over-the-counter prescription pain relief. Finally, while not in the Dear Colleague letter, we have found that the biggest complication with genital lesions is bacterial superinfection. And so we recommend frequent bathing, trying to keep that area dry, and changing clothes frequently. If infected, consider topical or systemic antibiotics, as well as wet to dry dressings for patients who may need some mild debridement. And don't forget about involving your GU colleagues if needed. So supportive care works for most, but some patients do require antiviral medication. In terms of indications for using antiviral treatment, which we list here as medical countermeasures, there are 3 categories. Severe disease, patients presenting with sepsis or requiring hospitalization, patients with hemorrhagic disease, large confluent necrotic lesions, severe lymphadenopathy that may be obstructing the airway, involvement of multiple organ systems, and you're getting the idea that severe disease can be a wide variety of significant complications from this disease. There's also involvement of anatomic areas, which might result in serious sequelae that include scarring or strictures, including lesions of the pharynx causing dysphagia, penile foreskin, vulva, vagina, urethra, or anal rectum, with the potential for causing strictures or requiring catheterization. There's also those who are at risk of severe disease, which is primarily individuals who are immunocompromised, as well as pediatric patients under the age of 1. In terms of medical countermeasures we have available, this includes vaccine immunoglobulin, cidofovir, brincidofovir, trifluridine, and tecovirimat. And we'll go through each of these one by one. The first is vaccine immunoglobulin. This is immunoglobulin to the vaccinia virus, and it's thought to have effects against Mpox as well. This has been primarily used for severely immunocompromised patients who you think cannot mount an antibody or immune response themselves, including patients who have severe HIV with low CD4 counts, or patients who may be immunocompromised due to organ transplants or chemotherapy or other oncologic process. In terms of antivirals, there are 3 systemic and 1 topical that I'll review. The first thing of note is that orthopox viruses are not herpes viruses. So acyclovir, which requires phosphorylation, is not going to be active against them. However, both cidofovir and brincidofovir are potential agents against orthopox viruses. Cidofovir diphosphate is a competitive inhibitor and an alternative substrate for DNA polymerase. It's incorporated into the growing DNA strand and blocks further DNA synthesis, leading to non-productive infection. Given the low overall mortality of this disease and the significant risk of renal injury with cidofovir, this drug has rarely been used in this setting, except for extremely immunocompromised patients with severe disease. Brincidofovir is a similar drug, but has a side chain that gets cleaved, releasing cidofovir, so it's thought to have less renal toxicity. However, in England, when the first 3 patients they had were treated with oral brincidofovir after the onset of rash, all 3 patients developed elevated liver enzymes, and none were able to complete the course of treatment, dampening enthusiasm for this agent, although it is available from the IND through the national stockpile and has been used again for severely immunocompromised patients, particularly ones who would be unable to tolerate cidofovir. Next, I'll mention it only briefly, but trifluridine drops. These eye drops are FDA approved for herpes infection of the eye and are thought to have activity against orthopox viruses. They've been recommended by the CDC in most cases of severe ocular disease. Finally, we have tecovirimat, which has likely been the most discussed antiviral during the course of this outbreak. Tecovirimat is an antiviral drug initially developed against variola to treat smallpox infection. It works by inhibiting viral protein P37, a protein that's highly conserved across orthopox viruses, allowing tecovirimat to have specific in vitro activity against many orthopox viruses. However, it would not have activity against other classes of viruses, including herpes viruses. Tecovirimat was approved in 2018 via the FDA Animal Efficacy Rule, or Animal Rule, which allows a pathway for approval of drugs for severe or life-threatening conditions when it's not ethical or feasible to conduct efficacy trials in humans. And so this was approved via that pathway for smallpox. And because it was approved through that pathway for smallpox, we actually had extremely limited human data on this medication prior to this outbreak. Efficacy data was done primarily through animal studies, and the human safety study that led to its approval included 359 healthy patients with only 1 serious adverse event that was not attributed to the drug. And in terms of efficacy prior to this outbreak, there was really just this one paper, the same one that included the patients who got cidofovir earlier. One patient was treated with tecovirimat, experienced no adverse events, and had a shorter duration of viral shedding and illness. However, one patient is more anecdote than it is evidence, and we've been gaining more evidence through the course of this outbreak. The first is safety. So the CDC published this data on safety, looking at individuals who were treated for Mpox under the IND between May and August 2022. They had almost 550 patients, 174 who had both intake and outtake forms. They all received tecovirimat between May and August 2022, and there were only 12 adverse events reported that you can see here, none labeled as serious. So while tecovirimat appears safe from this study, the bigger question is, does tecovirimat work? And there are lots of cohort studies and case reports that demonstrate people think that it works. Mpox virus-associated severe proctitis treated with oral tecovirimat, 2 cases, 26 cases from San Diego, successful outcome in a single case. And so people are curious about whether or not this drug works. In terms of data of evaluating the efficacy of this drug formally, this is really the first study that we've come out. And it's a study on the effect of tecovirimat on healing time and viral clearance by emulation of a target trial in patients hospitalized for Mpox. This trial had 41 admitted patients, 19 treated and 22 untreated, and they found no evidence for a large effect of tecovirimat in shortening healing time and viral clearance. Sorry. Additionally, the question remains about, does tecovirimat generate resistance? This study out of Los Angeles had 7 cases of severe Mpox treated with tecovirimat that did not improve with treatment. There's also this study from the CDC that's out in a preprint. It focuses on the Mpox F13L gene, where single acid amino acid changes are known to cause resistance. They have 50 isolates from 26 patients who were found to have a resistant phenotype. All of these were severely immunocompromised patients with multiple courses of Mpox. What's really interesting is that F13 mutations identified by routine surveillance in individuals who had not received long courses of tecovirimat have remained sensitive. And so the tecovirimat specifically selects for resistance in the F13 gene, where mutations in just general surveillance, not in people on long courses, have remained sensitive phenotypically. This really brings us to why we need a clinical trial. These case reports, observational studies, don't let us know definitively whether the drug works and is safe. We don't know if tecovirimat works to treat Mpox. There's no human data that yet confirms that Mpox is effective at treating Mpox. We need better understanding of the potential for Mpox to develop resistance to Mpox. Patients deserve treatments that work. If tecovirimat is not effective, we need to search for a new treatment. If tecovirimat is effective, we need to ensure that all people with Mpox have access to it. And the good news is that clinical trials are underway. The UK group, the WHO are all enrolling trials. And we have a trial here in the United States called the STOMP trial that you can learn more about on stomptpox.org. In terms of treatment, how do we access medical countermeasures? Tecovirimat is available through the clinical trial at stomptpox.org, as I mentioned. It's also available through a CDC EA IND with the pathway shown on the right. It's primarily for patients who are not interested in the STOMP study or not eligible for the STOMP study, as the CDC is encouraging individuals who want tecovirimat to enroll in the study if at all possible. Vaccinia immune globulin is available through a CDC EA IND. Brincidofovir is available through an FDA EIND. And for more information and links for how to connect to any of these, you can go to this website here. So we've now covered that Mpox is presenting atypically, can be a devastating and painful disease, and can potentially be treated with supportive care or potential medical countermeasures. However, how can we prevent Mpox in the first place? One way to prevent infection is through changing behaviors. The CDC has put together several great resources, including this one on safer sex and Mpox. And Dr. Daskalakis has made several videos and community engagement efforts to talk about how individuals can reduce their personal risk of Mpox, especially while awaiting things like vaccination. The CDC did this study very on that demonstrated that about 50% of people decreased their number of partners, decreased one-time sexual encounters, decreased sex with partners met on apps or sex venues, and decreased group sex. 42% decreased going to sex venues or events, and 35% decreased going to social events with close contact, like dance parties and raves. With that said, behavioral change is not a long-time solution. We want to be sex positive, and we want to encourage people to live and enjoy their lives. Behavioral change is really a means to an end, and that end is really vaccination for prevention. The first and best, as usual, way to prevent disease is through vaccination. There are 2 main vaccines. The first is ACAM 2000, a second-generation smallpox vaccine that is a live vaccinia virus. Just like with first-generation smallpox vaccine, you get a lesion or take at the inoculation site, you can see on the left, and it only requires 1 injection with a booster every 3 years, and is FDA approved for individuals age 12 and up. The second vaccine is the Jynneos vaccine. This is a third-generation smallpox vaccine. In this case, it's a live, non-replicating virus, meaning it does not cause human disease, and meaning it's safe for individuals who are immunocompromised. It requires 2 doses, 4 weeks apart, with maximum immunity occurring 14 days after the second dose. And it's FDA approved for those age greater than 18, although a recent emergency use authorization allows for its use in pediatrics. The vaccine can actually be used for both PEP and PrEP. For PEP, it should be given as soon as possible after an exposure. While there's no human efficacy data for PEP, non-human primate and other animal models suggest that giving the vaccine within 4 days may prevent disease, while giving it up to 14 days after an exposure may reduce symptoms. One thing to note, for patients who are not expected to respond to PEP or may not be eligible for PEP, vaccinia immunoglobulin is available as discussed earlier. For pre-exposure prophylaxis, the long-standing recommendation has been to vaccinate clinical and research lab workers and public health response team members. However, during this outbreak, we've started to vaccinate epidemiological risk groups or individuals who may be vulnerable to this disease. However, while we're talking a lot about vaccination, one of the big questions is, does vaccination prevent against Mpox? How effective is vaccination? Well, the truth is that we have no idea. The best data we have, and you sometimes hear this 85% number mentioned, know that it's from patients from 1980 to 1984 in Africa, vaccinated with prior generation smallpox vaccine. Observational studies from this current outbreak, however, have given us a better sense of the effectiveness of vaccination. So this is our first study from the New England Journal. It was published about a month ago, and it looked at the vaccine effectiveness of Jynneos vaccine against Mpox disease in the US. It was a case control study based on data from Cosmos, a nationwide epic electronic health record database. In order to assess the effectiveness of the vaccine, they created cases, which were 2,193 patients with either an Mpox diagnosis code or a positive orthopox or Mpox virus lab result, and then had 8,319 controls, which were individuals with an incident HIV infection or taking PrEP. So in spite of having all this data to work with, they did end up with a relatively small population. They had 1,792, a little over 2,000 case patients and a little over 8,000 control patients. And they found that the adjusted vaccine effectiveness for 2 doses was 66%, and 1 dose was 33%. And this is in line with what we've seen in several other observational studies. There's a multi-jurisdictional case control study published by the CDC and the MMWR that showed 86% for 2 doses and 75% for 1 dose. Another one by Rosenberg that showed 76% of 2 doses and 68% for 1 dose. And there are several studies looking specifically at first doses due to the timing of the outbreak that showed 76 and 86% effectiveness. So I think it's clear that vaccination is effective. And I honestly doubt there will ever be equipoise for a randomized controlled trial. So we may never know true vaccine efficacy, but I think it's clear that the vaccine is significantly effective at reducing at least medically attended or severe infection. We've also been wondering about post-vaccination and reinfection over the past year. There are now multiple case reports of reinfection, and while not yet published, the data from Chicago is about 2/3 of patients in that cluster were vaccinated. There's a current study, Mpox in people with past infection or complete vaccination course, a global case series, that looked at 37 patients, including 30 post-vaccination who had Mpox and 7 who had prior infection who had Mpox. These patients had less severe disease with fewer confluent lesions, diminished mucosal involvement, reduced analgesia requirements, and fewer admissions to the hospital. But in spite of the fact that we are seeing some post-vaccination and recurrent infections, these are extremely rare as evidenced by this chart. And so immunity from prior infection and vaccination clearly works, as we are not seeing a spike like we did last summer. And in summary, to wrap this all up, the current Mpox outbreak spread rapidly and can be serious. Cases are still occurring, although less frequently. It's not presenting classically, but it is presenting commonly with genitourinary, rectal, and pharyngeal complaints. It commonly looks like other sexually transmitted infections, but it can also present concurrently with other STIs, so don't forget about complete STI testing. We have supportive care and clinical trial options for all patients. We have EA-IND treatments for patients with severe disease or at risk for severe disease. More studies are needed to better understand the treatment options and long-term outcomes of this disease. Have a low threshold to think about Mpox in your patients. This disease can be stigmatizing and severe, and patients are grateful for our support. As a reminder from the New York City STD Prevention Training Center, We do have a clinical consultation warm line. If you have any questions about STDs in general, as well as about Mpox, you can go here. And if you're in our region, they'll come to us. I also want to highlight again the STOMP trial. If you have patients who test positive for Mpox, all patients who test positive are eligible for the STOMP trial. This includes individuals with mild or moderate disease who get randomized to TPOXX or placebo, although they do have the ability to move over to an open label arm if the disease progresses, as well as an open label arm for children, pregnant women, and those with severe disease. And with that, I'll stop and thank you for joining us today, and I'll take any questions. Thank you very much.
Thank you so much, Dr. Zucker, for that presentation. As a reminder to folks attending, if you have questions, you can drop them in the Q&A tab at the bottom of your Zoom screen. One question we have here is saying, since the vaccine can be administered either intradermally or intramuscularly, is either technique better?
So they both produce a similar immune response and appear to both be effective at reducing disease. The switch to intradermal from subcutaneous was mainly done due to a lack of vaccine availability. Intradermally is 1/5 the dose of the subcutaneous dose. And so we were able to expand the limited doses we had last summer to a much larger number of people. With that said, intradermal dosing does lead to more redness, more scarring, and more side effects from that standpoint, even though it's the same immunogenicity. And so most places, now that demand and supply are more equalized, have gone back to subcutaneous dosing for that reason.
Great, thank you. Not a question, but a comment here just saying thank you for highlighting the significance of bacterial infections of Mpox lesions. And one question is just around communicating with patients and how you talk about Mpox vaccination at this stage when folks are not seeing it so present, and how you kind of still convey, what ongoing risk there may be.
Mm-hmm. I think the biggest thing is reminding patients, just like any other STI, that it's still around, and that if they're starting to have symptoms, they should come in right away to be evaluated. Those symptoms may include dysuria or proctitis, things we'd recommend they come in and be evaluated for either way, because we'd want to test them for traditional STIs as well. But also if they develop any skin lesions, to come in and let us evaluate them as soon as possible. We don't yet have specific risk factors for reinfection and post-vaccination infection. Other than that, we're looking very closely. Like I said, we were trying to put together a global case series, and they're only able to identify 37 cases. And so I do think that so far, reinfection and post-vaccination infection have been much less common, demonstrating really the effectiveness of immunization and prior infection. And as we know with all immunizations, and they're not 100% effective, but they clearly are mostly effective, and people are not seeing large numbers of new infections.
Great, thank you. So I know you just answered that one question. Another question here. A number of my patients received a first dose of the vaccine last year, and what's the current thinking about their vaccination status now if they only received the first dose? Yeah. Do they start over, or would they just proceed?
They don't need to start over. They should get number 2. And we have been really encouraging people, especially this summer, to try to bring back patients who only got one vaccine to get their second vaccination, because it's clear that 2 shots are definitely, in every study we've seen, better than 1 shot. But there's no need to necessarily give them a second, 2 more shots, just the second shot. Yeah.
Great, thank you. That is all the questions that are in here right now. We'll wait a minute to see if anybody else has questions. Just as a reminder, you can drop questions in the Q&A tab. For everybody attending, you'll receive an email a little bit later today with CE instructions. The recording for this webinar, as well as the slides for this webinar, will be shared likely early next week. So please stay tuned for that, and feel free to share that with colleagues as well. One other question. For those who have high risk exposure who've recovered from Mpox, is there utility of vaccinating those patients?
Yeah. So there's currently no recommendations to vaccinate individuals who have prior infection, as it's thought that prior infection is protective, and that is bearing out in the data that we've seen. The majority of cases that have occurred have been post-vaccination. there have been very few reinfection cases. And so I think, at least for now, that's holding out. And again, there are people looking at sort of the duration of this immunity to figure out when they might need vaccination.
Great. And another question, for those who were vaccinated and had a significant skin reaction, are there any recommendations to help those patients?
So in general, most people who had significant skin reactions received the intradermal dosing. I don't know if that's exactly what you're talking about here, but then switching to subcutaneous dosing would be the right thing to do if they had a significant reaction to the intradermal dosing.
Great, thank you. Okay. Dr. Zucker, any final takeaways you'd like to leave the audience with today?
No, but thank you all for coming, and remember to keep your eyes peeled because we're definitely seeing cases.
Great. Ooh,
We got one more. Oh.
Yes, just a thank you. So thank you everyone for being here today. We really appreciate your time. Thank you, Dr. Zucker, for this fantastic presentation. As I said, I'll be in touch with everybody moving forward with CE instructions and a copy of slides and the recording. I hope everyone has a great rest of their day.